بسم الله الرحمن الرحيم. نبتدي الجلسة دي سريعا كده. معانا أستاذ الدكتور يحيى صلاح، معايا جنبي طبعا خالد عبد الرحمن. هنتكلم على اليوسيدس. اليوسيدس ادفانسد هي ادفانسد فيجنز. يوسيدس سيمالتينيوس ادفانسد فيجن. اتفضل يا دكتور.
شكرا دكتور فتحي بيه. صباح الخير. طبعا every one of us, all the patients, everyone wants to get rid of glasses when you get older, particularly seeing near. So you want to read, you want to see the computer, you want to see the car meter. And there are a lot of patients. We see a lot of patients. The patient demands are increasing. So we see presbyopes, they want to get rid of glasses, whether hypermetropes or myopes, or even patients with post-refractive surgery that they did in the first hand, the refractive surgery to get rid of glasses. Cataract patients without comorbidities, and now there are some studies showing that you can use these premium lenses in general in mild comorbidities that like early glaucoma, for example. We have so many IOL options, we have so many good options, each had its own technology, and we are confused. We don't know which one we use, from monofocal to extended depth of focus, trifocal. But I'm going to focus about extended depth of focus. But I just want to share with you that now, because of the so many different IOLs, everyone is claiming that he is doing so and so. So there are two bodies, the European Society Working Function Group that is working on new nomenclature just to define how to name and choose the intraocular lenses, and also the International Society of the International Standards Organization, ISO, which put very strict parameters to decide which IOL you can call it that name. And the idea is that we are used to divide the intraocular lenses according to their optics only, but we want them now to define functionally what they can do, so you can consult the patients easier and better and to be more clear. And this is the organization standards, and they put every group of the simultaneous vision IOL, which under it you have the mono vision, extended depth of focus, full vision range. And they tell you exactly what criteria it should fulfill this lens, so as you can name it extended depth of focus or multifocal or full range of vision. And this is the paper. It's a very important paper published last year in the the European Society of Cataract Refractive Surgery, Journal of Cataract and Refractive Surgery, dividing this into more categories, like 6 categories, just to help you clinically to advise the patient and choose between different types of IOL. Again, I remind you that patients now with the cataract presbyopes, they want to see near and intermediate, but they don't want to compromise distance vision. And this is very important point, that patients does not want compromise. They don't want halos, glare. They don't want to compromise. The demand is getting higher and higher. Just this, I'm showing this about the image quality in different types of IOL. I want to you pay attention in the upper right graph. You can see the bumps in the curves, and this shows you that bifocal, trifocal, they are very good, particularly even if most of them are diffractive, but there are gaps in between the range, different ranges, and this sometimes disturbs patients and annoys patients. So I'm going to introduce to you the Lucidis extended depth of focus. It fulfills the criteria of extended depth of focus intraocular lens. It is hydrophilic acrylic, and this is some of the critics against this, with 26% water content, 6 millimeter optic, and they have a special mechanism, optical functions I'm going to talk about, which is called pseudo non-diffractive beam. And there is a huge power range, haptic design, closed loops, which helps in stabilization of the lens. There are two sizes that you can fit, but in Egypt we have that 12.4 millimeter, which is more commonly used, but still there is another size that you can fit it in particular cases. And there is availability of the toric lens and the toric calculator, which is a great advantage, and the closed loop haptics decreases the possibility of rotation of this lens. So the main focus about the Lucidis, what is different? The difference is the technology, which is called the instant focus, which have there is an optic of 6 millimeter, mainly refractive, and there is 1 millimeter only in the center, which is aspheric, that works to propagate the wavefront of the light incident on the lens. And the great thing about it, it stretches the focus, the depth of focus line. As you can see here, it's very stretched, which gives a very wide range of focus, which allows you to see from near to intermediate smoothly without interruption. The light intensity is not dispersed, it's not splitted in this area. And this is very particular. There is no other technology like this. And also the 1 millimeter, there is no possibility of halos and glare almost. As you can see, it's a wide stretch through this 1 millimeter, the front interferences through this 1 millimeter aspheric surface gives this very long. You can see how long is the stretched depth of focus, which is what we are looking for. Of course, everything has advantages and disadvantages, so this can be dependent on pupillary size, as I'm going to talk about. And usually, this only 1 millimeter of this change can give as if there is a +3 diopters, which allows for very good near vision. And if you see the defocus curve, what explains, you can see this extended depth of focus, how large is the range. You can see that from minus 3.5, it's 0.6, the visual quality, and until plus 1.5, it's 0.6, the visual acuity. So this is a really huge, it's almost flat, extended depth of focus, which is not every extended depth of focus has this. And most of the extended depth of focus, even if they are good, they blend the distance, transition from distance to intermediate, like looking away and then looking to the cardboard. But with Lucidis, with this technology, it helps you to blend the vision from near to intermediate. So I'm reading my book, and then I can look smoothly without interruptions in my visual quality to see the computer or the dashboard of the car, whatever. And this is a very great advantage. So the instant focus gives us all these advantages that we talked about. And there are many articles that evaluates specifically the quality of vision, the halos, the higher order aberrations, wave, everything, the quality of uniocular, binocular, far, uncorrected, near uncorrected, intermediate. There are plenty of publications talking about the advantages of this lens and comparing it with other lenses. Like this is comparative study published in 2023 by Paul Dupierre, and with comparing it with three. All of them are nice, but it shows here that it has an advantage. The Lucidis has an advantage in the near and intermediate area. So what about the pupil size? Does this is a problem? Is it really a problem? It's not a big problem. Practically, clinically, in our work, it doesn't make a difference. But we have to be aware of this, that the best, which is the most common size of pupil between 2.5 and 4.5 millimeters, provides optimal performance. But what if there is a larger pupil, people having a larger pupil, and I'm talking about photopic pupil. If it's a larger pupil, most of the rays will go away from this 1 millimeter, and this enhances distance and intermediate vision, but may slightly reduce the contrast for near contrast sensitivity in dim light. But very small pupils, you would not prefer this unless the person with very small, like very old people having less than 2.5 millimeters, which is not common. These are the people that really actually wants very near vision. So they will have better near vision, but less quality of distance vision. So you have to look at the patient to look which, if he's a good candidate, well, pre-operative assessment is the same, from biometry, choosing the correct one, the topography, barometry. Ocular surface is extremely important, like all premium lenses, OCT and retinal evaluation. Advantages of the lucidis: minimize dysphotopsia, spectacle independence, rotational stability. And remember, the decrease in dysphotopsia is very useful, that we are used in premium IOS. We tell the patient you have neuroadaptation that will occur over 3 months, usually because this almost behaves like a monofocal. So there is no splitting of light. I mean, there is no diffraction. So people adapt very fast, particularly if you're doing bilateral. And you can use it with proper selection post-refractive surgery. And this is, again, very important, very useful to have such a lens. And we have a different example. You get used to it. The haptics a little bit different. So you can have a larger rexis if you want. If you have at the beginning a smaller rexis, sometimes there is some learning curve. You can use different types of injectors. You can use the single, like the Alcon injector or similar ones with the D cartridge. You can use a specific cartridge that they provide, so you can use single-handed or bi-manual technique. This is the D cartridge, and you have to load it. It's soft. The haptics are very malleable, 6 millimeters. It gets into the bag perfectly. So if you get it in the bag well-centered, the centration is perfect. And having only 1 millimeter that is effective in this instant focus technology, so a little bit of decentration will not affect the quality of vision or the performance of the lens. And even more decentration for any reason will affect maybe the near and intermediate, but will not affect the distance vision, because it will act like a monofocal lens. And this is a very good, a great advantage. So you can see, you can clean it. This is used, again, sometimes if you have a small rexis, better, particularly in the early time, better make like a 5.5 or 6 millimeter capsular rexis. This makes it easier to lead the haptics into the bag. The haptics are malleable, but once in the bag, the lens is perfectly stable. So you see, once haptics are properly positioned, gently, although you can see the lens is perfectly centered. Again, this is the last. This is a little bit small rexis. So you do your technique, you finish your surgery, fill the bag with viscoelastic, and then you can implant. This is the cartridge. Now it is supplied with as an injector with the lens. So just make sure when folding this, putting it in the cartridge, to make sure it doesn't close on the haptics, or otherwise it can tear it. Even sometimes if the haptic is torn, still you can place it and the lens is centered. You see, it's a little bit difficult to manipulate with the small rexis, but once everything is under vision, anterior chamber is well formed, so you can manipulate very well. So, in conclusion, Lucidis can provide spectacle independence, either partially or fully, with a smooth transmission from near to far, and it is an affordable lens. Most importantly, it provides distant visual acuity that is compared to monofocals. It has minimal, if any, photic phenomena, so there is no neuroadaptation, and it is forgiving for some biometry errors. Thank you for your attention.